Hi, I'm Janet Trautwein. I'm the CEO of NAHU, and I'd like to talk to you today about how NAHU works at the legislative and regulatory level on Medicare issues and what we do for you as a professional organization for people who do what you do. So let's get started. Anytime we talk about what's going on legislatively or from a regulatory basis, we have to start off talking about politics. Because the fact is that in Washington, D.C., the political issues and policy issues are all interwoven with each other. And when decisions are made, these political consequences are taken into consideration before members of Congress do really virtually anything. So I'd like to start to talking with you about the makeup of the House and the Senate, because it matters a lot in terms of what can happen and what is not going to happen. We'll start off with the Senate. So the Senate just is made up of 50 members or 100 members of Congress. Right now we have a 50-50 in terms of Democrats and Republicans, members of the Senate. And what you can see on the chart here that it says we have 48 Democrats, we have 50 Republicans. The two independents caucus with Democrats, so they are counted as Democrats. And then in the event that there is a measure that's going to be voted on that requires a tiebreaker vote, which that would only be issues that are subject to being voted on with a simple majority. I'll talk more about that in just a minute. Then Kamala Harris, as the vice president, would be the tiebreaker. So in the event of a tie, anytime in the Senate, anytime there's a tie, then in the vote, then whoever is the vice president is always the tiebreaker. And we'll talk about how that has recently worked in just a few moments. But most measures are not able to pass with a simple majority in the Senate. Most things have to have 60 votes because they're subject to things like filibusters, parliamentary holds, and some other procedures that are only in the Senate. And those require 60 votes, so kind of a sort of a supermajority. There are very few that only require the 51 votes. Those would be things like reconciliation bills and a couple of others during the year. Sometimes appropriations bills only require a simple majority in the Senate. And by the way, this is a midterm election year. I'm sure you're all aware of that. We have an election coming up in November, and it's the first election following a presidential election. And I mention that because it's more than often really, excuse me, most of the time, whichever party is in the White House, at the first midterm election that follows a presidential election, whichever party is in the White House, the other party is the one who really gains a lot of seats in both the House and the Senate usually, but certainly in the House, and sometimes in the House it can be a lot of seats. So as we look coming up at the election we have coming up this November, and we can see how close it is with Democrats and Republicans, there is a really strong likelihood that Republicans could take over in the Senate. And by the way, members of the Senate run for 6-year terms, and only 1/3 of the members of the Senate are reelected for each 2-year election. And as you see, the two leaders right now, Chuck Schumer is the majority leader in the Senate because Democrats are in control. Mitch McConnell is the minority leader. And after the midterm election, these two people will also be the same two that are in control, the same two that are today. One will be the majority leader and one will be the minority leader, and we don't know that yet as to which will be which. And I want to talk about the House. Now the House, every measure pretty much passes with a simple majority. So it's much easier to get things through the House, and oftentimes we see legislation that passes through the House and then it just goes to the Senate and sort of gets stuck there. We often joke that it goes to the Senate to die, because if it's not a measure that can get those 60 votes, it's just not going anywhere for the most part. But you can see here that Democrats and Republicans, Democrats are definitely hold the majority, but it's not a very big majority compared to the way it was before the last election. So most of the political prognosticators are predicting that Republicans will take over, and this is because of that issue that I just mentioned, that the first midterm election following a presidential election, the other party from who's in the White House usually gains a lot of seats. And because they don't need to gain a lot of seats in order to take over the majority, Republicans are predicted to win. Now, I want you to look at who the three leaders are that we are showing here, because these may change, and they are actually likely to change. In fact, all three of them may change. So let's talk about that to start with. So first of all, Nancy Pelosi is the Speaker of the House. And at various times over the last many years, she has been a minority leader. And then when the Democrats had the majority of representation, she would take over as a speaker. So she's been the speaker or the minority leader for a long time. And she is quite popular among the members of her caucus. She's really well able to control the way they vote. Probably as speakers go, she's one of the best in terms of controlling her own caucus, which is one of the primary jobs of the Speaker of the House. Now, Nancy Pelosi is running for re-election again. And I mention that because she's 82 years old. And oftentimes people will retire when they get to that point. But she probably will not be the next speaker or the next minority leader. Even though she's running for Congress again, she definitely is going to win her election. She's actually the biggest fundraiser for Democrats. So she's really a super fundraiser for her party. Not only does she get herself elected, but she gets other people elected as well. But she's unlikely to run for speaker again, or if she does, she's definitely going to be challenged by others. And the next person up in line is Steny Hoyer, but he's also 82. And it's likely that there will be younger people that will run for the seat. There's a lot of discussion about the need to bring some of those younger members of Congress that are up and coming into the leadership, more into the leadership than they are today. One of those is Hakeem Jeffries from New York. He's considered kind of a front runner, but he may not be the one that ends up being the Democratic leader, whether it's majority or minority. And then Kevin McCarthy is of the Republican minority leader now. We've worked a lot with Kevin McCarthy over the years, and he's easy to work with. By the way, also Nancy Pelosi's office has been very good to work with over the years. We always work with whoever is in the leadership with both parties. But Kevin McCarthy has said a few things relative to President Trump that were not popular with some members of the Republican caucus. So he's definitely going to be challenged. Whether or not the challengers will be able to get enough votes to become the minority leader is still up for grabs. But none of these three may actually end up being the leaders after the November election. That's what I wanted to point out to you. And why is that important? Well, it matters who the leaders are because they kind of decide what the agendas are and how things go with their various parties. Particularly whoever's the majority leader, speaker, really decides a lot as to what is going to come up for a vote at all. And they have a lot of control over not just whether things pass, but whether they even get a vote. So it's very important as to who these are. So as we get closer to the election, and certainly following the election, you should definitely watch to see who the winners are in these races, because it definitely will affect you in terms of the things that are looked at by Congress, things that are good for you or things that aren't good for you, as in terms of the way you operate your business and the way your clients experience the Medicare program. A lot of that has to do with who these leaders are and what the agendas are, also who the committee chairs are in the various committees of jurisdiction. So keep an eye on that. So we have just very recently had some very interesting thing happen. You may have known that the Senate has been working on a reconciliation bill, which is it's a budget reconciliation bill. It's one of the few types of measures that only needs a simple majority to pass, but everything in the budget bill has to have to do with either taxation, saving money, spending money. It can't be about a policy issue. So for example, if the Senate wanted to get rid of the filibuster, they could not do it with a budget reconciliation bill. So the one that they've been most recently working on has been called the Build Back Better, and they've had a lot of trouble getting consensus within their own party to pass this. But it's just recently passed the Senate, and probably by the time you are watching this, it will have already passed the House. And it was reconfigured and is now known as the Inflation Reduction Act of 2022. And it passed the Senate on August 7th, probably by the end of this week that we're recording this, it will have passed the House. It is definitely a smaller package than what it was starting off. In the end, it came out to be $470 billion, which sounds like a lot of money, but at least it's not the trillions that they were talking about passing before. And it ended up focusing on just 3 areas. So prescription drug prices, climate issues, and also tax credits. And the main things that were included in it relative to healthcare, and I'll get into some more detail about that in just a moment, but is that it would allow the Secretary of HHS to negotiate drug prices for Medicare. And a lot of you have probably heard this thrown around about, we need to be able to negotiate drug prices. And you probably wondered why it wasn't happening already. So when the Medicare Modernization Act passed some years ago, and it included the original Part D, there is a provision in it that forbid this HHS to negotiate the prices for Medicare, even though Medicare itself and the federal government pays for 75% of the cost. So the amount that your beneficiaries and maybe even you pay for Part D is not the whole cost. Those premiums are only 25% of how much it costs. So there's been this big groundswell for a number of years now saying, look, if this is a Medicare program, Medicare should be negotiating the cost of drug prices. And so that was one of the big things that was in there. I'll give you some details on how that price negotiation would work. And then it also, the other really big thing it did that a lot of people who work in the individual market are really happy about is it extended the American Rescue Plan, the Affordable Care Act's premium tax credits. Those tax credits would still use the formula that's being used today, not the one that was the original tax credit formula. So many more people are eligible for a tax credit under the American Rescue Act formula. And so a lot of people who otherwise weren't able to even afford insurance are now able to afford it because of the way those are structured. And I think before I want to tell you the other things that are specifically in it, I'd like to talk about what's not in it. Because over the course of the last couple of years, there have been a number of things in this reconciliation bill that were not good. So one of them would have created lowering the Medicare eligibility age to 60. Now this, you might think that sounds good, but first of all, it probably wouldn't have included you participating in it. And second, it would have done some other things to really destabilize the individual market for people that are age 60 to 64. It would have created an unlevel playing field that would have really favored the lowered Medicare eligibility age as opposed to private coverage that was offered through the exchanges. And also we were able to get out of there any type of public option. Those were in there as well too. So those again also are market destabilizers. There were also some penalties for employers for mental health parity that were really penalties that would have been unavoidable because of the provisions of the way they would have applied, would have really not allowed any employer to escape them. We were able to get those out of there. And then there was a provision in there, again, relative to employer-sponsored coverage that would have lowered the rate for affordability to 8.5%, which would have really been very harmful for employers who hire a lot of lower income people, people that work in sort of transitory situations. So think of hospitality industry, nursing homes, agriculture, other businesses where there's a really narrow profitability margin. Those are the ones that would have been affected by that. And some of them would have stopped offering coverage to their employees. And then the other thing, we really worked against capping the insulin price because of the way the wording was structured for the private market. And we'll talk more about how it applies in the Medicare market in just a moment. So none of these provisions made it into the final Senate bill. It was clean and absent of these provisions. Now, some of the details. Here's how the drug negotiation will work. First of all, it won't start until 2026. At that point, HHS can begin negotiating on 10 drugs, and then another 15 will be added in 2028, and then another 20 beginning in 2029. And they'll look at the drugs that are, the most commonly used drugs, the drugs where there are, pricing issues. They'll select these very carefully as to which drugs it will begin with. And another provision that did make it in there is that drug manufacturers would be penalized if prices increased faster than inflation. But this provision only applies to the Medicare market. It doesn't apply to private market plans. And then for the Medicare market only, it caps the cost of insulin at $35 a month. And it caps, this is something that you all would probably be very glad to hear, is that it caps Part D spending, beneficiary spending at $2,000 a year, and allows all Medicare beneficiaries to receive any type of vaccine at all at no cost. So these are some things that people have been really asking for. There were a lot of other things that didn't make it in there that would have been very, very costly, would have likely increased, the cost of Part B even higher than it already is, increase the cost of Part D. And these are things that actually lowered costs and allowed some savings to come into the overall reconciliation bill. So I'm going to talk about a few other things that we're working on. One of them is COBRA as creditable coverage. And if you've heard us talk before, we've been working on this for quite a while, but the issue with COBRA as creditable coverage, for any of you that may not be familiar with this, when someone works for an employer and they have employer-sponsored coverage, and either they terminate their employment or maybe they reduce their hours so they're no longer eligible for their employer's coverage, they may go on COBRA for a variety of reasons. Perhaps they're currently in treatment and they don't want to change their network. Maybe they've already met deductibles and co-insurance when they go on COBRA. Maybe they have a spouse that they're covering along with their plan, and that spouse maybe is younger than them. So they have all kinds of reasons where they might elect COBRA. But the one thing that they don't think of is that when they elect COBRA, they believe they're continuing their employer-sponsored plan. And they don't realize that from Medicare's viewpoint, as soon as they elect COBRA, it's considered individual market coverage. And at that point, it triggers their Part B enrollment period. And that's only for a 6-month period. And if someone doesn't know that they need to be enrolling in Part B, and not to mention the cost of enrolling in Part B, then that is a big problem. And oftentimes people end up with penalties for life because they didn't enroll in Part B on a timely basis. So we have legislation that we're working on, HR 2564, and it's bipartisan legislation that would change the way COBRA is treated under the Medicare program, so that it would be treated the same way that employer-sponsored coverage was, as long as someone was on COBRA. And we've had this passed out of committee, but because of the pandemic, there was a lot of momentum lost and there was a lot of focus on other issues. We hope that we can get this going again soon, and our bill sponsors are looking for ways for this to happen quickly. We're really pushing to try to get this done this year. And there are a lot of ways to get it passed this year, either getting it through on its own, but more likely is that we attach it to something else that Congress has to pass, which would probably be, or most likely it would be the end of the year, probably in the lame duck session, which is the session post-election during December and part of November. One of the other things that we're still working on is observation status. So I have a feeling that pretty much all of you have run into this with your clients before. So observation status is an issue where, I'll just give you an example. Let's say a person falls in their home, calls 911, an ambulance brings them to the emergency room. It's a pretty bad break, so they can't just fix them up and send them home. They need to keep them for a while. They're on Medicare, maybe they're elderly, and they need to be watched for a little bit longer. So they'll put them in what looks to the patient like it can be just a wing of the emergency room, but most likely, oftentimes they'll put them even on an inpatient floor, but they will be classified as being on observation status. And the hospital has an incentive to do this because they are penalized by the Medicare program if they have too many readmissions for letting people go home and then they come back and they're readmitted. So and this is from having been an inpatient. So if they leave them on observation status, those penalties don't come into play. Unfortunately, for the Medicare beneficiary, it is a problem because often this person visualize this person that we're talking about, after a few days, this person still may not be able to go home and be in a safe environment, particularly with a fracture, and they may not be able to get around well. They may live alone. They may have no one at home to assist them. They may not even have running water at home. So often this is rural areas, and what they really need is to go into a skilled nursing facility for a little while so that they can recover more before they go home. Unfortunately, if they were classified as observation status, that means that they didn't have the required 3-day inpatient stay that allows Medicare to pay for a skilled nursing facility. And often people don't even realize that they're on observation status, or they don't understand what it means. They go into skilled nursing because that's the safest place for them to be, only to discover later that none of it is covered by the Medicare program. Now, what's interesting is that this has been waived during the pandemic period, and with no big cost to the Medicare program. So we are hoping that this will continue. We have legislation pending that would change it permanently. We almost feel like this could be changed on a regulatory basis as well. But our legislation, you can see the bill numbers here, HR 3650 in the House and Senate 2048. A lot of momentum was lost on this issue due to the pandemic, with the exception that they did actually waive the requirement, but the actual legislation passing didn't go anywhere because they didn't need to. So theoretically, enforcement will continue on this after the emergency ends, which was July 15th, and I think it's now been extended one more time. But as soon as the public emergency officially ends, then this leeway on this issue that has been allowed during the pandemic period will stop, and the rules will go back to the way they were. So we've been pushing really hard either to get this legislation passed or to get this to be a permanent regulatory fix. And we're hoping that that occurs very soon. We'd like to look at it as something that could be done at the end of this year like the COBRA as creditable coverage issue. One of the other things that happened during the pandemic period is that CMS broadened access to telemedicine services for Medicare beneficiaries because people just could not get out to their physicians. And prior to the pandemic coverage, Medicare had a rule that you could use, telemedicine could be used, but it was under really strict circumstances. It had to always be with a physician that you had seen before. So it didn't allow for other uses of telemedicine that have been widely used during the pandemic period by Medicare beneficiaries. Just to look at the numbers, you can see them on the screen here. Before the public health emergency, there were perhaps 13,000 beneficiaries that received telemedicine in an average week. But just looking at the CMS's own records for this, during just one snapshot of a week, April 26, 2020, nearly 1.7 million beneficiaries received telehealth services. So obviously, this is a needed service and should actually be a cost-saving service. Again, this flexibility will end when the public health emergency ends. Current date is October 13th now, and we'll see if it's extended beyond that. But we are hopeful that, again, that this can just be a permanent change that the Medicare program makes. Beyond that, we also have legislation pending that would make it permanent. It's bipartisan, and that would extend these flexibilities through 2024. It's been passed by the House, and now it just needs to be considered by the Senate. We do think this is something that has a very high likelihood of passing. And then I want to talk for just a moment about single payer. And I would just say that we've worked very hard in opposition to Medicare for All. And I mentioned it to you here today, even we're talking about the Medicare program, to point out to you that Medicare for All is not Medicare. Medicare for All would actually take Medicare away from everyone that has Medicare. So many of your clients may hear about Medicare for All, and they probably like the Medicare program, and they don't understand that this would be very bad for them. So we've worked very hard in opposition to this. It would actually reduce their access to coverage because of the way your providers would be paid and the way global budgeting occurs and that type of thing. But it would actually would impose if it did pass, it would impose one of the strictest single payer systems in the world, and actually much worse than the Canadian system. So we've really opposed it. We've been able to keep it pushed back. We think we've got it pushed back, but your clients may still ask you about it. So make sure when they ask you about it that they understand that this is not something that it might sound good because they use the word Medicare in it, but it's not something that would be good for them. And the overall cost of the program, by the way, I say that it would reduce payments to beneficiaries, but it actually, in spite of that, or not to beneficiaries, to providers, in spite of that cost saving, it is estimated to cost $32 trillion over 10 years. And the average tax increase per household would be $24,000. So even though it would be said to be free, it's not free. And it would actually cost quite a bit, both for the federal government and for those of us who pay taxes. So it's really not anything that's viable for our country, and would be unacceptable in terms of our access to healthcare. So to make sure if your clients ask you about it, don't just say, oh, that's not going anywhere. You should explain to them why it's not a good idea anyway. Please take the time to do that. Another big issue coming up is Medicare solvency. I know that you've probably all heard that Medicare is going broke. It's going to become insolvent. And the fact is that the Part A trust fund is scheduled for insolvency in 2028. Having said that, I will say that there's no way that Congress will ever let Medicare become insolvent. Seniors are the biggest voting bloc that there is in our country, and it would not be a politically good idea for them to let that occur, even if it weren't the wrong thing to do anyway. So they'll continue to work on this. But when we hear about the insolvency, we're talking about Part A. So that's the part that's funded through the deductions from people's paychecks. And the deductions are just not enough to keep track with the number of people that are aging into the system. So they have to figure out an additional way to fund that program. Part B is not a part of this. Part B is funded 75% by general revenues that Congress appropriates and 25% by Part B premiums that people pay. The same thing applies to Part D. So when you hear about insolvency, they only have to fix Part A. It's not that we don't need to bring down costs in the rest of the system, but this actual trust fund issue is a Part A issue. Some of the things that they're looking at are whether they're looking at things like whether they should modify the way nursing home payments work, whether or not they should look at coding intensity. They're talking about site neutral payments to make sure that Medicare is not overpaying for services in certain areas, more aggressive pay for performance models with various providers and so forth. So, but they're also looking at whether or not they should increase the payroll deduction amount. They're looking at whether or not they should, some people are suggesting, although I don't think this would pass, whether they should increase the eligibility age. We did that for Social Security to make sure it was funded years ago. And there are many people that are proponents of making people eligible for Medicare at the same time they're eligible for Social Security. So these are just some of the things, and there are other items that they're looking at as well, but these are the most common ones that you'll hear talking about. So this is something to watch. It's very important. And your clients may also be worried that their Medicare is going to go away. So this is something to talk to them about. It's very important that they understand that this is an issue that Congress will be able to fix, but they shouldn't, at the same time, they shouldn't take it for granted, because some of the ways that they fix it may be some changes for them. So it's something to watch, but not something to worry about. So when will Congress fix it? Well, we're in a midterm election year. The margins are the closest in Congress since 1896. So they're not going to completely restructure the Medicare program in that kind of a political situation. Remember, I started off saying that good policy is always intertwined with what the political realities are. But they'll probably do these kind of smallish changes and do enough of them to result in enough to extend the trust fund some period of time, and maybe not a permanent fix. It isn't that they won't eventually come up with something that's more permanent in nature, but they may be just doing this in small pieces to get it a little bit further and a little bit further as they look for more systemic ways to make the program run more cost effectively. So I want to talk a little bit about regulations, and I know this is something that many of you are pretty concerned about. So we'll talk first of all about some new changes to enrollment and eligibility rules. So you may already be aware of this, but this, and I'm going to kind of speed through some of these in order to spend more time talking about the Medicare recording issue, which I know you really do want to talk about. But under the most recent proposed rule, which came out at the end of April, Medicare coverage would become effective in a slightly different way. So it'd be the month after enrollment for people that enrolled in the last 3 months of their initial enrollment period. And the idea with this is that they would reduce any potential gaps in coverage. So, and then it also created some additional special enrollment periods. So make sure that you're aware of what all of these are. So some of them have to do with people that were impacted by a national disaster. They would have a special enrollment period. If a health plan or an employer made an error, that would allow a special enrollment period. People who had been incarcerated and who needed to enroll after they were released would have a special enrollment period. A special enrollment period for Medicaid beneficiaries when their Medicaid was terminated. And then also one that's called for exceptional conditions. And we actually think that perhaps the COBRA issue could fall under this last special enrollment period if in fact the legislation does not pass this year. The other thing that has changed, and there are actually two things here. One of them is, I'm sure that you're aware that end-stage renal disease is considered to be a qualifying event for enrollment in Medicare, regardless of a person's age. So Medicare coverage extends for 36 months under this end-stage renal disease provision, unless a person ages into the Medicare program, or unless they're considered officially Medicare disabled, Social Security disabled. So one of the problems with this is that often if a person has had a transplant, they have to take immunosuppressive drugs for life in order to continue to keep their organ functioning. And if their coverage stops abruptly, and these medications can be quite expensive. So if their coverage stops at 36 months, it can have drastic circumstances. So assuming that this rule will be finalized, a person who doesn't have other health insurance coverage would be allowed to enroll in Part B, even if they were not otherwise eligible beyond that 36-month post-transplant period, to allow them to continue. And this is a very huge improvement. And then just one of the other things, just for sort of a heads up, there are some other changes being considered for end-stage renal disease that have to do with the way it's covered under employer-sponsored programs. So you should keep your eye on that. There's a lot of discussion about it right now. And I won't go into any details here because it's really all in the discussion phase, but it's doesn't look very good for employer-sponsored plans with the current discussion. So we'll see how far they go. And then I want to talk about the recording of your telephonic conversations with your beneficiaries that is scheduled still to begin on October 1st. So we have had numerous meetings with the CMS and the people who wrote these rules, who are really, this is really just overreach for a problem that is created by the TPMOs. Think of this as, many of you are quite familiar with the Joe Namath commercials. Nothing against Joe Namath, but there's a lot of the commercials are kind of misleading. They turn into, and I'm sure you all know about the 25 calls that your clients get every day from people who aren't supposed to be calling them without a request first. And so a lot of this was designed to hone in on where the actual problems are. But unfortunately, they did this broad brush approach that pulled in everyone involved with marketing and not just those who are the bad actors. So we are still working to get this changed. One of the things that we have talked to them about is making sure that they are defining what a TPMO is and not pulling in independent agents who are legitimately marketing according to all the rules that there are, and pull them into this requirement for recording. That's still a possibility that they would change that definition. One more likely is that they might delay this. And we are also requesting that they delay any of these changes until they've had an opportunity to see where the problem actually is and observe that during the 2023 plan year. So we've asked them to look at that, take the balance of this year, including all of the annual enrollment period for the 2023 enrollments, and to meet with all the stakeholders but also to observe market conduct and gather feedback, and then craft a reasonable proposal, which we are quite certain at that point would exclude independent agents. So we're hoping we can at least get the delay, if not just a complete change in the definition. And we're still working on it. We work on this all the time, and we're looking at it from a lot of different angles. So we're still working on it. And one of the things that we have also looked at is changing some other things that would be important, and to be sure there are some changes that would be helpful to be made. One of them is to make sure that there's the multi-language insert is inserted with any sort of marketing material, the mandatory enrollee ID card standards, which have kind of fallen by the wayside, and also making sure that plans have instructions on their websites explain to beneficiaries, explaining the enrollment process in case the beneficiary goes there first. And obviously you, the agent, are going to explain that all to them. And I want to tell you that oftentimes when we run into things like this marketing and recording of calls issue, there are a lot of things that we run into, and we don't think about the things that have gone well. One of them is that we've been able to repeal the disenrollment period for Medicare Advantage and restored the January open enrollment period. There was a guideline, marketing guideline 120.44. You probably forgot about it now, but we were able to get that removed. We've been able to get legislation introduced relative to COBRA, as well as the observation status. We've gotten restrictions that would have imposed even worse restrictions than what we're talking about with the recording on Medicare Advantage and Part D choices for seniors. Those things are gone, and we forget sometimes that those things were there before. There have been additional marketing restrictions that we've been able to get rescinded, especially as it relates to Part D. We've also gotten some value-based design into Medicare Advantage, which allows those programs to continue to operate at a low cost for beneficiaries. You may not know that we were responsible for HSAs coming into existence, not just in the Medicare program, but also for anyone who has an HSA. And those were included in the Medicare Modernization Act. We've gotten the changes. Some of you may not, if you haven't looked at the CMS Plan Finder lately, you probably don't notice all the changes that are in there. A lot of the things that were problematic when CMS made the change have been changed now. Also, there were much more restrictive scope of appointment requirements than there are today, and we were able to get all of those out. So it's just sometimes we have to work on things for a while before we can get them taken care of, but we are diligent about that, and we're well respected by the regulatory agencies as well as members of Congress. And so we've been able to get these things done. And the last thing I would say is, if you're not a member of NAHU, I hope that you will consider becoming a member. It is quite affordable. You can join on our website at nahu.org. And I will tell you, why should you join? We are your professional association. One of the main things that we do, it's not the only thing we do, but one of the main things we do is that we work on legislative and regulatory issues. This is your future, and I strongly encourage you to join now. By the way, a lot of you who complain about the AHIP certification program, we have one. NAHU has one. It was written by agents for agents. I highly encourage you to check it out. We've got almost all of the carriers on. So go in and see. You can find it on our website, and go in and see whether or not the carriers that you represent are included. And we have a lot of other Medicare resources for you. We have a Medicare web portal. We have a discussion area for people that are that work in the Medicare space. We have all kinds of things that are available to you, as well as We have a Healthcare Happy Hour podcast, which you should definitely check out. It's very, very good. We have a daily newswire that shows you the news items of the day, weekly Washington update, and we also have a state update as well as a Medicare newsletter. So I can't take questions from you now because this is recorded, but you can always reach me and ask questions that you have. There's my email address. You can see it there, jtrautwein@nahu.org. So thanks very much for listening today, and I hope to see you in person very soon.